So I'm going to talk today about copy number alterations in breast cancer, and I'd like to focus. The work that we've done has been using the version 2 of the Oncoscan array, and I'm going to provide some examples from our work. So the outline for my presentation today, I'm going to talk a little bit about breast cancer. I'm going to describe the early stage breast cancer cohort that we used for the Oncoscan, for the MIP arrays and the analysis that we've done. Also, I'll give two examples. One will be looking at a gene called LRIG1 and breast cancer outcomes. And I'll provide another example from some of our work on prediction for site of metastasis among these patients. And then some summaries a summary at the end. So in general, in the world, we would expect this year about 1.7 million new breast cancer cases, and about 520,000 women will die from the disease. So this is a very prevalent and a problem worldwide, and it's something that is of concern, and I know the numbers of patients here in Japan are increasing, and they are in other parts of the world as well. In the United States, and this is why I want to focus a little bit on the early stage, about 98% of the women with early stage breast cancer will survive 5 years or more. If the woman is diagnosed with a regional stage at diagnosis, about 84% of those women will survive 5 years. And then in every country, any woman who's diagnosed with a distant disease, stage 4, has a much poorer prognosis, and about a quarter of those women will survive 5 years. So I'd like to just put some of the things I'm going to talk about into perspective and just to provide some definitions of what I am going to address. So I'd like to just define what I mean by prognosis, and this is prediction of the probable course of disease and an estimation of the likelihood that the patient will recur or progress or relapse. So the work that I'm going to be showing you is looking at prediction models and trying to understand, using some of the genetic work that with the MIP arrays, how we look at these kinds of likelihood of recurrence. And then what I mean by prediction is whether the woman will have, or a person will have, a treatment response, and whether or not a certain drug will be used. So this is the difference between prognosis and prediction. So in terms of some of the prognostic and predictive biomarkers and clinical characteristics in breast cancer, we've known about many of these types of prediction markers: the estrogen and progesterone receptor, HER2, Ki67 is often looked at as a proliferation marker to determine how well somebody might do with their in terms of prognosis. If they have some of these different characteristics, they would do better or worse depending upon the characteristics of their tumor. In terms of the clinical characteristics, we often have looked at patients' age, if they're pre or postmenopausal, that more women who are premenopausal at diagnosis have a poorer prognosis. The tumor size is obviously an important factor in looking at prognosis, as well as whether there's spread to the lymph nodes, if it's local or regional spread, and the histologic grade has been a significant prognostic marker. So in terms of making decisions, at diagnosis, clinicians want to try to provide the best treatment that they can for somebody. And what's really important with these prognostic markers, in some cases, when we're calculating a person's risk, and there's certain tests that are now being used, the Oncotype DX and some of these others, to try to determine how well will this woman do at diagnosis. And we want to do better in terms of being able to assess that, better than flipping a coin and knowing that a woman might have, or a person would have, depending upon some of these models, would do better than by incorporating some additional information, that they would do better than just flipping a coin. And this is really important because we don't want to overtreat or undertreat a person, that if we know that they're going to do worse, we might be more aggressive with treatment options. So the next thing that that has been important in terms of trying to understand risk for breast cancer is the Peru intrinsic subtypes. And these subtypes, this is a heat map just showing the differences by those patients that had basal-like or luminal A or luminal B types of breast cancer. But what's really important is to look at this, these Kaplan-Meier curves. And because there are now multiple different types of breast cancers, and they can be subdivided into these categories right here, you can see that the lines on this Kaplan-Meier curve are really separate. So when we look at the best type of intrinsic subtype, we're going to see these luminal A patients. And, you know, once you can identify these women that are at lower risk, you might treat them differently than you would somebody who has a triple negative breast cancer, or here what we call a basal-like, and that their prognosis is much poorer. So I think that the information that we're learning now over the years by putting these types of things together is we really are able to know that there's different types of breast cancer. Breast cancer is not just one disease, and neither is other cancers. And having these types of models where we can incorporate these factors and separate them out, we can really understand more about how we treat the patient. And this is what's really driving all of us here, and what drives many of the technology and what we know now is the promise of the omics. And this has really changed science, especially over the last few years. And I remember when we first started doing even just GWAS and different kinds of things with SNPs, that we had, you know, a few markers, and now you can run so many different types of arrays, and the omics technology is improving astronomically, and I think that this has really changed the way of us doing our research in the face of science and clinical medicine. And really, when we think about this, this provides patients with now personalized diagnostic information. There's treatment options based on what their genomics looks like in the tumor or in the germline. And it's now we can use this for prognostication, for personalized medicine, or what we call predictive medicine, and trying to determine a patient's risk of disease recurrence. And I think that's really key, is that we want to be able to treat people so that they don't recur. We use the omics to determine aggressiveness for treatment and how aggressive we should treat them, that if they're in a really high-risk group, that we would treat them aggressively rather than those, like I just showed you, the patients that might have luminal A, we might treat them less aggressively. So we want to really make sure that we can treat appropriately, but also reduce the comorbidities that could occur with treatment. And we know that for many patients that are overtreated, that they have significant sequelae of comorbidities. They could have neurotoxicity. They could have, you know, many types of toxicities that are related to their treatment. And I think what's important now, as women or patients survive their cancer, we want to make sure that we can reduce the morbidity that they would face in the future. Also, the omics has provided incredible information for us to understand biology and to give us insight into these different factors that really is biological differences. And so the goal is to be able to predict, to tailor treatment, and to reduce toxicity and have a better response for their treatment. So I'm going to provide some examples, and the cohort that I've used we call the early stage breast cancer cohort, and these are women that were diagnosed with either stage 1 or stage 2 breast cancer, and these are women that you would expect to have done really well. They would be in that 98% or 90% 5-year survival rate. And we wanted to understand when we started this study, why is it that these 10% of the women or so don't respond to treatment? Why do they do poorly, and how can we focus on those that are at this highest risk group and try to understand what is driving their cancer to recur? So this study we started with we went to I was working at MD Anderson at the time, so we went to our resource, our files, and we identified about 2,300 patients that fit the eligibility criteria for the study. Then we went to our tumor bank to identify matched samples so that we could have clinical data and the tumor samples to be able to run the arrays that we were going to be measuring copy number. And when we ran them with the Oncoscan, 32 of the samples failed, and we ended up with about 971 patients in our study. So what were our endpoints? We were looking at breast cancer recurrence, and we were also looking at death, whether it was from any cause mortality or from breast cancer. So we had multiple sources where we were able to follow the patients over a long period of time, and we had the cancer center would follow patients each year to see if they don't come back to the cancer center, whether they were still alive at each year when they sent them a letter. And then we also followed patients through a Social Security death index, which also allows us to be able to see if the national death index knew that that person was alive or dead. And we also then followed up our patients and called them on the telephone if we weren't sure whether they were alive or dead. So we really wanted to make sure that our endpoints were right, that we knew whether a person had recurred or metastasized or was still living and doing well. So this is just a slide describing the patients, the 971 patients that we identified and had tumor. And the goal when we were analyzing the cases is that we thought maybe there were ethnic differences. And in the United States, we have multiple ethnicities, but we had patients of African American descent and Hispanic patients, and we were curious whether their tumors behaved or if their clinical prognosis and these characteristics were the same by ethnic group. We didn't have very many in these two groups that we were able to look at this very meaningfully. But the mean age of our patients were between 55 and 52. You can see that many of them were postmenopausal, but we also had younger patients. We only included those patients with stage 1 and 2A and 2B. Fairly similar across the ethnic groups. And then here's the distribution right here of the subtypes. So we wanted to recapitulate and look beyond the intrinsic subtypes that have been characterized by Peru et al. And so you can see here that there are differences actually by ethnic group. About 27% of the African Americans were diagnosed with triple-negative breast cancer. And the distribution looks from our population like you would expect others to look. This was because they were stage 1 or 2. We had some patients that had greater than 2-centimeter tumors. Probably about 60% of them had much smaller sized tumors. Some lymph node involvement. And you can see here about half of the patients, 40 to almost 50%, had treatment, chemotherapy, and did have endocrine therapy. So this slide might be a little bit hard to read, but this is just in general, without bringing the omics into the equation, is just looking at how the population did. These patients were pre-Herceptin. They were also patients who came to a cancer center where the treatment was much more aggressive, and even though these patients were diagnosed in the 1980s through the early 2000s, because we were looking for long-term follow-up, you can see there are patients that had no treatment. And so I think what's interesting to point out here is that there's major separations between the patients that didn't have any treatment. So if we see this line right here, these are the black line is the luminal A's. And even though there were some patients who probably would never be treated, who would be treated regardless, now that we know that they had triple-negative disease, you can see that there was the poorest survival group. So this group, I think, what you would expect right here, this is statistically significant between the groups. And so this was baseline looking at the time to recurrence. So what we did next is our goal was to, because we had tumor samples, and many of these tumor samples that we identified from our archive were old. Some of them were from 1985, but it was a source of tissue that's available, and many people that are doing research, the go-to place is to go to the tumor banks to be able to identify samples if you're doing a retrospective study. So we worked together with Affymetrix, and this we published this paper in 2009. And these data were from the development of the version 2, the first version of the MIP arrays. And so we were really interested to make sure that the array worked well with our data. And what was really important when we identified that this was the array that we would use to analyze our data, what was important, we didn't need very much DNA. The assay worked great with about 37 nanograms of DNA. It had high quantitative accuracy, and I'll show you a little bit of the data. It was really forgiving for the fragmentation with really high dynamic range. And the probes, there were 330,000 probes on this array that crossed the entire, all of the chromosomes across the genome, and also included were about 400 selected recurrent mutations. And to be honest with you, we weren't really able to use those the mutation data. The version 3 is significantly better. It was built with working with people who were studying breast and ovarian cancer, and this was the Stand Up to Cancer group, and so Affymetrix worked with them very closely for the new version of the Oncoscan to incorporate most of the known genes that are important for breast and ovary, but also for other cancers as well. So we think that the mutations that are now included in the version 3 are much better than the mutations that are here. So this is just, I think all of you know what the Oncoscan, the FFPE assay is with the MIP array, but here's just a little bit of a schemata, how the probe binds to the DNA in this kind of circular way. The endonucleus is added, it's cleaved, and goes through this process, and you get data that I'm going to show you in a minute. We also use, and I think this is included in the, when you're analyzing the data, we use this Nexus software that was developed by BioDiscovery, and I think it works really well. And they've now included TCGA data so that you can compare the data that you're getting from the Oncoscan with the genome, the Cancer Genome Atlas data. So what was really important for us, and when we worked with the developers of the array, what was important is how well does the FFPE work against the gold standard of the fresh frozen tissue. So we ran paired samples, and this was published in 2009. I can't remember exactly how many pairs there were in that paper, but we had a significant number that we were able to see that the assay worked well with FFPE, and that was our goal, is because that was the tissue that we had. And if you look at this, you can see that the separations and the patterns between these two panels are very similar. That the gains on chromosome 14 were similar here with the gains from the fresh frozen, and each of these dots indicates one of the samples that were either had copy number gains or losses. So we thought it worked really well, and we were impressed with these data, and we felt confident that we could continue working with the FFPE samples. So here is just looking at the data. The other thing that was important for us is to be able to see, are there differences by each of these tumor subtypes? And we had 971 samples. That's everybody together right here. So this is before we separated them by luminal A, luminal B, HER2 positives, and the triple negative breast cancers. And I think what's the take-home message for this slide, which is important, is that there are differences in copy number that we were able to identify by these different intrinsic subtypes. So if you see a little dot above or below the line, that means that there was a significant difference in these copy numbers by subtype. So I'm going to now provide some examples of how we use the data once we were able to look at this, and we had some questions that we were interested in for looking at the Oncoscan copy number data. So one of the recent papers that was just published in June in Cancer Research was called LRIG1, Copy Number Imbalances and Clinical Outcome in Estrogen Receptor Positive and Negative Breast Cancer. And I had several colleagues from Sweden, and they have been doing some functional work and some fish. They were doing some work with fish with this particular LRIG1 gene. And they knew that we had this large data set, so they asked us if we could validate the work that they did with the sample set so that we could see how well whether or not we could predict breast cancer metastasis in this population. So just to give you a little bit of information about LRIG1 and breast cancer, it's a break point in LRIG1 is at exons 12 and 13, where there is a copy number gain, and it's been associated with HER2 amplification DNA in a DNA-based alteration. So and also the evidence for LRIG1 expression is higher in estrogen receptor positive breast tumors, and this is inducible by estradiol, and it's associated with better progression-free survival. So that was when we started to look at our data. This was information that we knew that was important for us to be able to validate. So this is just looking at the location on chromosome 3p14 and the locations. So we had to recapitulate the region here of the, sorry, I think the thing isn't working. So the FISH probes that they identified were right here between the MIP5 and 6 to 11, and then there were other MIPs that were downstream of that location that they identified. So we incorporated these locations together from the data that we had. So just looking at the time to relapse to see whether or not that the data looked like we had expected from the functional work, I think what's important to see here that if a woman had gains in LRIG1, the survival and prognosis was really outstanding. If they had a loss, the survival was much poorer, and these are people that had no copy number alterations in LRIG1. So one of the questions that we asked is that what happens when you go beyond the 5 years? And we wanted to see whether or not the time to relapse for those patients who did well, are there those that we could separate by time of their follow-up time. So if you look at this right here, you can see that we started at the 5-year point, and you can see that there was almost, if they had a gain, the survival was almost perfect. If they didn't have, if they had the loss, that there was a significant, these are statistically significantly different, these curves. So what was really important, we also then conducted a Cox proportional hazards model to determine the risk for recurrence and distant metastasis for a copy number imbalance in LRIG1. So just looking at the data, we separated it by any recurrence or whether they had a distant metastasis. And so what was significant, if the woman was less than 50, and we know that from the clinical characteristics when we see breast cancer patients, that their risk is actually higher. And we showed that in our group with the clinical data. Tumor size, we always expect that if their tumor size is larger, their risk of recurrence is also greater, and we see this in our data. And then again, if their lymph nodes are positive. So this is these variables without incorporating the LRIG copy number. So when we add the copy number information, if they had a loss, they had a twofold risk of any recurrence. Basically, it's these hazard ratios are similar. But if they had a gain, you can see even though it's not significant here, it was protective. So in summary of this section, genomic loss near the 3p13 region is an independent risk factor for poor survival. The LBRIG1 loss is a major driver event in this region and significantly associated with distant metastasis, and that this risk persisted beyond the 5 years post-diagnosis. We found a higher frequency of loss in both Black and Hispanic women that were associated with this LRIG loss, and it was also more frequent in patients that had triple-negative breast cancer or HER2 positives and the luminal B type, which is also a worse prognostic group. So these probes flanked the exons 12 and 13, and it supported our hypothesis of a breakpoint in this gene. So I think what's important here is that we feel that this gene could be included in prognostic, as prognostic arrays or assays are being conducted, that we feel pretty confident that if somebody had this, that you could use this for treatment options. So if you went back and you looked at that one, those Kaplan-Meier curves that I showed you, that if you had that gain, that you really would actually have a great survival, and that you may not have to be treated as aggressively as you would if you had the loss. But also we think that this could be a druggable target, and we're working with others right now to see if the possibility of possible targets for treatment. So the next example I'd like to provide is some work that we did, and this was published earlier in the year, where we were predicting whether or not a woman would recur or metastasize and looking at the site of metastasis. So we thought, how could we use the MIP array to see whether or not we could predict whether or not a woman would have a recurrence at a specific metastatic site. And metastasis, as we know, is what kills the woman from when she is diagnosed with breast cancer. So the sites of metastases that are most common in breast cancer are bone, lung, liver, and brain. And in terms of the background, estrogen receptor status is important in bone metastasis. And the women who have estrogen receptor positive tumors are at higher risk of developing bone metastasis. And other factors for non-bone would be age, estrogen receptor negative, or if they had triple negative breast cancer, that they might be more likely to develop a non-bone metastasis. We were also looking at major changes that drive site-specific metastasis. And the first paper that we published from our data set, we developed this 17-gene signature. And this signature actually really worked well with patients that had ER-negative disease. And so we're hoping right now with the new research that we're doing that we could perfect this, this signature, and hopefully we could develop this, that it might be one that could be used like the Oncotype DX, which is only used for patients that have ER-positive disease. And so no study has really looked at these copy number imbalances to see whether or not we could predict which patients might have a specific site-specific metastasis. So again, just showing you the data, we used the same cohort of patients with early stage breast cancer, and this, if I just call your attention here, so we looked at the data. There were 11 patients where we didn't have any metastatic information, the site of metastasis or any information about whether or not they metastasized, and we had 960 patients that we had information and follow-up information about their whether or not they had any metastatic lesions. So in terms of the numbers, 757 of them had no metastasis, 74 had a bone metastasis, and 129 had a non-bone. This paper was published, the original paper that we had was published in 2007 that described this population. So part of getting any paper published, and I think all of you know this, if you don't have a validation set, you won't be able to get a paper published in the literature using any of these types of data. So we struggled hard to try to find a data set, and one of our colleagues from Norway had copy number data, and we were able to compile, and we actually downloaded these from GEO, from a publicly available data website, but these were colleagues of ours from Norway and Sweden, and they had 4 small studies where they did conduct a copy number. They had copy number data, but they did not use the same array that we used. They did it with another array. So we ended up with, they had 335 potential patients, and we excluded those that were either stage 0 or stage 4 because they already had metastasis at diagnosis. And this is the breakdown of the number of patients that were included in the validation set. So there was about 76 that total that had any metastasis. 26 of them were bone, or bone as a first metastasis site. 50 had non-bone metastasis, and there were 3 patients that had multiple first sites of metastasis. So they could have had a brain metastasis, a bone, or any one of the other sites that we included, or liver. So this is just the description of the clinical characteristics of our patients. As I mentioned, there were 74 that didn't have any metastasis. There were 259 in that group, and these were how the distribution was. We had, remember, our patients were early stage. They were treated mostly with chemotherapy. And so the median time from first metastasis was about 4.6, 4.7 years. This group was much different because they didn't treat them as aggressively as the patients in our cohort. The median follow-up time was about the same, 10 years. And if you looked at the age at diagnosis, you can see that it's about 40% were less than 50 that didn't have a metastasis here, so there is a slight difference. And those that were non-bone, about 52% were under age 50. So that's the group that you would actually expect that would do worse, would be those that were younger, sorry about that, this group. We also then looked at the tumor subtype because we thought that was, another important characteristic to look at, and here's just the distribution of those by subtype. Again, we would expect that those that had triple negative might do worse, but there are differences. So those with the non-bone that had triple negative, about 31% of those, which was fairly high, versus 5.4% of the bone metastasis. These numbers are relatively small to really describe here. So here's just some of the data of the Cox proportional hazards model for risk of bone metastasis. And I think what's important here is, just like I showed you on the last slide, that actually if they had triple negative breast cancer, they were less likely to have a metastasis to the bone. I think the points I want to make here, that if the tumor size was slightly larger, they were at increased risk of bone metastasis. Endocrine therapy, that they didn't have endocrine therapy, that they were at greater risk of developing a bone metastasis. The lymph node status, if it was negative, they were protective. And so then what we did is we added in the copy number imbalances, and these were the 3 that fell out. We looked at the entire data set to see which ones that, once we looked at all of the data, could be important in predicting bone metastasis. And these 2 were significantly associated, and it was validated in the group right here for the 8p22 loss. So these were significant. These were less significant, but when we analyzed our data in the model, they seemed to be relatively important of the top 3 markers. So when I talked about earlier that we wanted to be able to develop prediction markers, instead of flipping a coin, we want to see how well we could predict what the site of metastasis would be, including the clinical data, the different types of tumor subtypes. And so if we look down here, that just looking at the risk factors, not taking into account the markers, we could flip a coin, but we would do a little bit better, like 21% better. So this is the index that says, okay, if we put all of these factors together, how well could we predict whether a woman would have a bone metastasis based on these factors. So here was, if we looked at the C index for just the markers by themselves, it really was just 13% better than flipping a coin. But when we incorporated these into the full model, our C index improved to 75%. So there still needs to be a lot more work where we can bring this index up maybe to higher than 80% or more, where we could say, okay, if we were going to test your sample before you or at the time of diagnosis, we might, right now with just the data we have, we could be about 75% sure that if you had some of these characteristics that, and these particular markers, that you might be then in that high-risk subgroup. If we look just at our validation set with these markers, we got up to, with the markers in the clinical data, we got up to about 86%, so that was a lot better in terms of the validation. Here is looking at just the non-bone metastasis data, and here we showed that about the patients that metastasize about 2.5 risk of if they were in this group or this group, so they were significantly higher depending upon their subtype. And here, looking at this by stage of disease, about a 4-fold increased risk in our discovery set. We didn't see the same hazard ratios in these groups to validate that, but the numbers were relatively small. When we added in the markers right here, this 7q21 increased, there was a 4.15 increased risk, which was pretty significant. And the marker here, the 11q, was about a 2-fold risk. And then when we computed and we calculated the model to determine prediction, just these markers, right, these factors right here, the C index with these risk factors was about 70%. And actually, the copy number didn't do much better than just flipping a coin, but when we incorporated them together, the improvement was about 71%. And here, the validation seemed like it was going in the same direction. So clinicians like to look at Kaplan-Meier curves to see what the data look like between the discovery and the validation set. And you can see that all of these are significant and that there's a clear difference in these curves where we can look at the high-risk groups that would have poor survival over time. So this is the timeline. So what we looked then is what genes are important in those areas where we identified the copy number. And so we went back to the different data sources to see where does that match up. How do we take that particular SNP and see what is the target and whether or not it makes sense that there would be biological significance about some genes in those regions that we identified, because you can see that we had a fairly large region. This 8p22 started at 6, had the start and stop point. So it was a fairly, these were fairly large enough regions that we wanted to look at the genes that could be important as potential targets. And so there were genes in those areas that looked like they could have some potential targets. These genes were associated with metastasis. This DLC1 is a predictor of bone metastasis. This OMP is close to a metastasis gene called EMSY and an LRRC32. The same LRRC32 was, because both of these genes were important, and you can see that there was some significance for us to go back and look at those targets. So just to summarize, the risk factors that were important for bone metastasis were tumor subtype, tumor size, whether or not they had endocrine therapy, and lymph node status. And these were the copy number imbalances that were important. And we were able to validate this particular 8p22 loss. And for the non-bone metastasis, we had slightly fewer clinical factors, tumor subtype and stage, these two markers, and we were able to validate this particular gain in the validation set to predict bone metastasis, non-bone metastasis. So in conclusion, we had a very large sample size. The cases came, at least for the discovery set, came from a single treatment center where we had validated long-term follow-up, including the first site of metastasis. So it was a fairly enriched data set where we had a lot of clinical data, long-term follow-up data to be able to see how these patients would do over time. We identified specific copy number imbalances that increased the risk for bone and non-bone metastasis. We were able to independently validate the data, and some of the copy number imbalances really help us to enhance the discrimination of high-risk tumors within these particular breast cancer subtypes. We were able to validate our findings, and this was really the first study that was published where we were able to use these copy number data to determine some information about metastatic sites. Our results strongly suggest that these markers are their underlying genomic drivers, and they have the potential to be used clinically as biomarkers to potentially used for treatment, post-treatment surveillance, and to identify high-risk patients who would be likely to benefit from more aggressive treatment. So just in summary, we have now published about 6 papers with the copy number data, and we've been really impressed of how well these Oncoscans and the arrays work in our research activities. So I'm happy to open this up for questions and answer any questions that you might have. Any questions? I'm happy to answer them now, or if you'd like to ask me later, I could. I'll be standing around.
Okay.
Thank you for your nice presentation. I'm Hiroaki Ito from Showa University. I'm surgeon. And I have one question. What part of sample extraction point from FFPE, for example, proximal or central of tumor, what do you recommend? Sample extraction point.
Okay, so what's really important when we cut the slides, we would cut about 10 5-micron slides. And what's really important, and you would know that as a surgeon, that there could be a lot of tumor heterogeneity. So what we try to do, and we have one, when we cut the slides, the first slide that we would stain and the last slide we would stain so that we could, have sufficient, we'll know how much tumor is available on each of the slides. So we asked the pathologist to take the slides and to circle where there's the most tumor on that particular slide. So that's what we use, we would scrape that off to then extract the DNA. And it's really tricky. But my colleague, Dr. Patricia Thompson, who's been at the University of Arizona, is the expert. So if you have any questions or need any help with, how that's done, I'd be happy to put you in touch with her. That's your question, right? Yeah.
I can recognize that.
But the beauty of this array is that you only need 37 nanograms of DNA, so it works really, really well. And I think now it's even less. Is that correct? If they perfected it, it's still about 37 nanograms, which is a pretty small amount. But you want to make sure that you have the most tumor in those samples, because if you look at our earlier paper, you'll see that there's a whole, in each of the Kaplan-Meier curves, there's a group of patients that don't have any copy number alterations. They're copy number neutral.
Yeah.
And so we're not sure whether those patients are really truly copy number neutral or whether or not we had maybe too much heterogeneity in the sample that we had, and there was less tumor. Less tumor available.
Thank you very much.
You're welcome.
I focus on research for circulating tumor cell, but I'll try. Thank you very much.
Thank you.
いかがでしょうか。
Thank you for giving me an opportunity to listen to your lecture. My name is Assay Kurozumi, and I'm a surgical oncologist in Saitama Cancer Center. I have one question and my suggestion about triple-negative breast cancer. In clinical situation, triple-negative breast cancer includes low expression of HER2 breast cancer. For example, in the histochemistry of HER2 expression is 1+ or 2+, and in situ hybridization is negative. In my research, about 20% of triple-negative breast cancer has intratumor heterogeneity of HER2 expression. I think that intratumor heterogeneity of HER2 may be the prognosis factor of triple-negative breast cancer and may have the efficacy of trastuzumab. What do you think about the intratumor heterogeneity of HER2 in triple-negative breast cancer?
I'm not sure I quite understand the question in terms of. Ask me that last part again. I'm not sure I quite understood what you were.
Sorry, I want to know the importance of intratumor heterogeneity of the breast cancer tissue of any biomarkers that when we use anti-biomarker therapy.
You're talking in general about whether or not there's clinical arrays or ways to use some of the different clinically.
Yes.
Okay, I see what you're saying. So one of the things that many doctors use for the if it's estrogen receptor positive, they use the Oncotype DX. Is that what you're saying? Is how do we use some of these different arrays to be able to determine prognostic factors for these patients? Is that what you're saying, prognosis? Right now, I don't think that there is any of those assays that work well for triple-negative breast cancer.
Thank you.
Sorry, that we think our array our marker set that we published would work well for the triple-negative or the ER-negative patients.
Oh.
We're in the process right now of conducting a validation of what we published already, and we're looking at patients that had neoadjuvant treatment first, so that we could then see how well we could predict survival and prognosis in those patients, because we know that they're already at that if they had neoadjuvant treatment, that they would do worse. So we're trying to develop our prognostic markers based on those higher risk patients.
We just trained. Thank you.
Thank you.
Hello, I am Masaru Kato from National Cancer Center, and I have two questions related to amplicon at the 11q13.5. You mentioned that that region amplified in breast cancer with bone metastasis, as well as breast cancer with non-bone metastasis.
Okay.
So my question is whether the amplicon in two separate metastases are overlapping or separating?
I think they must be overlapping a little bit. We're trying to separate it out even more, but that one gene seemed to be important in both of them. So I think what separates it out is the 7q and this 8p right here is what really separates these off. This wasn't as significant, the XP11, but I think having the 7p really does separate these from each other.
And
if you go back and look at the non-bone, you can see that the 7q was 4 times, and here it was 2 for the 11q. And if you went back to this particular slide, you can see that it was about twofold. So it seems like this gene right here was the loss on 8p was important for the bone, and the 7q21 actually probably drove it even more for the non-bone.
I'm afraid my question was not correctly. Question was not might not be understood correctly by you.
Okay.
My question was whether region amplified in bone metastasis and non-bone metastasis are identical or overlapping or slightly different.
We tried to separate these patients out. So if they had bone only, they went into the bone only. If they had others, then they went into the non-bone, but we kept those really separate. And we had the data from both data sets to be able to separate those patients out so that, we looked at the site of first metastasis, and it was that site.
Sorry. Perhaps definition of separation is not correct. I use when separate, separation means separation on the genome, not separation of a site.
He's talking about the complication of the samples. So the copy number again, so we have non-bond and bonds. What are the difference between those two gains? Like they're both in the same region. But do you see difference or?
Yeah, I don't know the answer. I don't think I don't know. I have to go back and look at that paper to see if we. I'm not sure. I'm going to go back and look at. Do we have the copy? I have a copy of the paper. I'll give it to you to see if we had. I think there could have been some of that in the supplemental information, but I think that they were probably fairly close.
Almost identical.
Well, because on that one slide, this one right here, when we looked at this, we mentioned that the genes in that region were similar, so the potential targets. So my guess is that they were pretty close. Even if, wait a minute. Yeah, because they're slightly different, because here the start is 76.2, 76.7, and here it's 75.7 to 76.2. So this is right. They're not overlapping. Sorry. Now I see your question.
Okay.
Do you see the point? Do you see? Do you see
Yes.
what I'm saying? This stops where that one starts.
Okay.
Yeah.
And the next question is: are there any microRNA on the amplicon? If there is such kind of microRNA, it can be used as a diagnostic marker by using circulating microRNA detection.
It's a good point. You're right. I'm not sure if we have the data to be able to look at that.
Thank you.
他にございますでしょうか。
Thank you very much for your nice presentation. I'm Sugano from Tochi Cancer Center. I have a question that is there any specific copy number abnormality for the subset analysis? I mean, is there any specific copy number alteration for luminal A or luminal B or triple negative? How about the result of such subset analysis?
Yeah, I wish I would have brought all of that. I only had an hour to talk. In our first paper that we published, we did develop our prognostic markers based on each of those types of intrinsic subtypes. That paper was published, it's number, it was in PLOS One, so it's this one right here that was published in 2011, number 5. So in there, we looked at it it's a very detailed paper, and there's a lot of supplemental tables where we did look at the copy number and the imbalances by intrinsic subtype, and there are differences.
Oh, thank
And
you.
that's what I was saying, when we built the one model worked really well, we think, for the ER negative, and we got a subsequent grant after that with the data that we had to start working more with the ER negative group.
Thank you very much. And my second question is, have you had experience of a comparison between Oncotype DX and this assay?
So we're in the process right now of the new data that we're working on with our new study is all based on the version 3. We've analyzed right now one plate. We're ready to send a second plate to them, so we had about 100 samples, and it worked really well. We did a head-to-head comparison between these data and those for that first plate, and it worked really well. And what's, I think, much nicer about the new version is having the mutations on it. We just submitted an abstract to the San Antonio breast meeting because we identified some unique P53 mutations based on the somatic mutations that were available for from that array. So we're testing that now by taking those samples to make sure that what we see is really true. So hopefully by the time the San Antonio meeting comes in December, we'll know how well those work. But we think that it is a much better version and also takes into account the concerns that we had with using FFPE and it being forgiving to small amounts of DNA. We're also doing another head-to-head comparison with a colon cancer study that we're doing of patients that were diagnosed with young onset colorectal cancer. And so we just did about 50 samples with version 2. Now that version 2 isn't available, we're going to rerun all of the samples with version 3, so we'll be able to do another head-to-head look at those. I wish I had that with me today because I think that's important for this group to see. Any other questions?
他にございますでしょうか。
My name is Yuji Kato. Sorry, I ask in Japanese.
Andy will translate.
コピーナンバー以上のマーカーのそのプレディクティブなバリューというのはどれぐらいあるんでしょうか。そのサブセットでそのボーンメタ骨メタに対するその治療の走行に何か関係するようなデータっていうのは得られていらっしゃるんでしょうか。
Well, I don't think right now it's being, our work isn't being applied to treatment. We think there's a lot of potential for it to be, especially the LRIG1 can. And one of the things that I didn't mention, which I think is really unique to the Oncoscan, when we had this old data set that was from starting back in 1985, HER2/neu was not tested in those patients. So when we had the copy number data, we were able to recapitulate the HER2 whether it was positive or negative, by the number of copy numbers that were expressed. And we went to AFI and we said, you could pull this out of the array to be able to run HER2 because it recapitulated beautifully. So it's a much easier assay to run, and you can be using it for some of those types of things. So we're hoping in the near future that we'll be able to develop our model that could be used clinically and have treatment, some treatment options and decisions.
あといかがでしょうか。あ、はい、もう一度後ろお願いします。
I'm sorry, I would like to ask in Japanese.
Okay.
一つそのこのツールを使うときに マイクロダイセクションしてそのがんを分けていらっしゃるでしょうかっていう質問をしたいんですけど、マイクロダイセクションでこうがんのところを分けてそれから解析をしているかどうかをまず聞きたいんですけど。
We didn't use microdissection. We didn't. I think I don't know if I. Why don't you so I answer the question correctly? We did not use microdissection. So we had our blocks. We cut 10 5-micron sections, and we circled on the first, the front end of the cuts. We did H&E, and on the back end we did H&E, so that we saw what we had throughout the entire each cut and each slide. And then what we did is we circled where the most tumor was. And that's kind of how we handled it. But we did not microdissect.
Oh, okay, I see.
But
Thank
you probably could. I mean, I don't see why you couldn't. We just didn't do it. We didn't think we needed to do that because there was enough tumor available.
なるほど。ありがとうございます。
We've done other samples, and we had glioma samples that we ran this on, and we took, the pathologist kind of took like a shaving of it, and, we used that to extract the DNA.
I see. Thank you.